All right, so we have a case. It's a 65-year-old male. He's 5'9" tall. He weighs 250 pounds, and he has a sedentary lifestyle. He's manager of a public house, which means a pub. 5 drinks daily, which is perfectly normal. Former smoker, 20-pack-year history, stopped 5 years ago. He's an only child, and his father died suddenly when he was 10. They're unsure of the cause, but he was a heavy smoker and overweight. Excuse me. 5 years ago, this man had a bilateral hernia repair with mesh placed. The wife insists he goes to the primary care, who he last saw 3 years ago. At that stage, there was no PSA check. His GU complaints are nocturia by 2, slow stream, post-micturition dribbling, and worsening ED. He does mention recent onset of mild back and right hip pain, which began when he started evening walks 3 times weekly. Exam confirms truncal obesity, blood pressure 145/90, regular pulse. Right hip has mild pain on flexion, no spine tenderness noted. Rest of the exam is normal, except for a firm area 2 to 3 centimeters on the right base and a moderately enlarged prostate of 50 grams. This was a good primary care doctor. CBC, creatinine, electrolytes normal. He does a PSA on him this time, and his PSA is now 45. He's referred to his local urologist. Rectal exam confirms the finding with the suggestion of CT3 disease on the right. Prostate biopsy is discussed. He undergoes a 12-core transrectal ultrasound-guided biopsy with an oral antibiotic coverage, which reveals a 70-gram prostate with Leeson score 4+4 in 2 of 2 cores at the right base, and mid with 50 to 70% core involvement. Findings are discussed with he and his wife. Bone scan is ordered, which is negative, and the patient wants to proceed to active therapy. So how should one proceed? Dr. Rossi, want to go first?
So my approach at 65, complex. You're worried about many factors here, but like you said, wants to proceed with active treatment. A 65-year-old by Social Security Index, actuarial tables, has on average a 20-year life expectancy, and we have to think longevity here. I don't like this scenario at all, of course.
Yeah.
I would proceed with an MRI to complete staging to kind of get a look around. It sounds like he has a high IPSS score. I didn't gather, but it sounded like it was pretty
20.
significant. I would see the patient in a multidisciplinary scenario, see the patient with the urologist, and have a multidisciplinary plan. What is on the table from a radiation perspective with high-risk disease? If you follow NCCN guidelines, this is what they're going to say. If beam, it's definitive beam with 1.5 to 3 years of hormonal therapy. If you use combo therapy, you can drop that down. Now it says 1 year. Before that it said 6 months, but it doesn't say 0. But I'm real, I don't know if you'd say this conservative with hormones. This is a guy that I'm looking for an option away from hormones, but he does have definitive options that we can offer him.
Okay.
You would shy away from brachy in a guy with a situation like this unless you can really tune him up. Maybe he has a big median lobe that can be hit first, and then we can come in second. But is he a surgical candidate?
So, let me just go back to the imaging. This guy had a PSA of 45.
Yeah.
Real strong smoking history, right?
Yeah.
He quit 5 years ago?
Yeah.
I would do a CT scan, chest, abdomen, and pelvis. Sometimes we get surprised and see second primaries in the chest as well, and that's part of my standard workup on imaging.
Okay. Neal?
I absolutely, regardless of his smoking history, I would have done a full body CT scan because leaving it just as a simple bone scan to rule out metastatic disease is not adequate. Of course, I'm assuming his CBC and his CMP were normal.
Yeah.
I'd want to get that. The guy is, he's morbidly obese. He's got some family history. He's a smoker. He clearly needs, if he hasn't had a good primary care or cardiology evaluation, that needs to be considered as well. I've been to the Public House. It's a great restaurant.
Yeah.
Then we're, left with assuming all those things are negative, then you're looking at all the usual primary interventions. That said, he's certainly at high risk for failure.
Okay. So he's given all the options, surgery, radiation, cryo, and is aware that if he has radiation therapy or cryo, he'll require ADT and may also require it post-surgery. Now, I should move and say this has got mixed up. He actually had enough money that we suggested to him that he might consider an oxygen scan. And that was what he actually went with. And the scan suggested that he had nodal disease in the obturator and iliac nodes, and they weren't huge, but he also had lit up his spine in two areas, L3 and L4.
Were his nodes above the common iliac?
Yeah.
And was it pretty bulky?
They were, yeah.
So now, are we calling him a high volume or a low volume guy?
Well, I'm going to get to that.
Okay. Right.
So if you had your choice and you had your money, and I realize that he wouldn't be allowed to have an oxygen scan, well, you'd have to make a good argument to get one from Medicare, etc. But which of these two modalities would you prefer if you had your choice? Would you go with an oxygen scan, or based on what you've seen coming out of Australia and other places here and the work going on in the United States, would you go with a gallium PSMA scan? And I'm biased in this one, but I'd like to see what you guys think.
Tom, I don't understand the question.
If you had a patient that you're looking to see if they have metastatic disease, say the CT scan is relatively normal, would you move to an oxygen or a gallium with the PSA of 45, Gleason 8 disease, T3 disease on clinical exam?
Assuming access is equal.
Yes. Because we've all seen I've seen the data from Australia, so it's about time we started getting it out and talking about it. Would you go with the oxygen?
Yes.
Or would you go with the gallium?
So I think we've been, in the U.S., we've been rather restricted because we only have the Axumin. And I don't want to be overly provocative, but I guess I will be. I think PSMA gallium will become the standard of care, and I don't think Axumin will continue much longer. PSMA gallium will hopefully be here. We've heard, from various folks sometime in 2020.
Yeah.
And that based upon the data out of Australia, Michael Hoffman's work, and others in Europe, certainly out of Germany, that will be the standard of care.
And I think with a PSMA, you can detect things at a PSA of 0.2,
yeah.
Whereas with the Axumin, I think it's 1.7.
Yeah.
1.5.
They do. They have one coming out. So PSMA gallium, well, there's I think about 7 or 8. It's fluorinated, correct, with an RH 7.3. So yeah, so the bottom line is that the world's going to change. We're way behind the rest of the world in terms of PSMA gallium.
Agree with you 100%.
Yep.
All right. So how does one define, I was asked about the volume of metastatic disease, and I believe this is another major problem that we have. Because if we look, this is the original description. This came from Mario Eisenberger's paper. This was done by Dr. Glass, published in the Journal of Urology. And she basically included, yes, bony, but she also included PSA. She also included performance status. And she also included Gleason sum. And I think that when you looked at it, she was able to distinguish 3 very different groups: low risk, intermediate risk, and high risk. And my question really is, when we compare studies to one another, we shouldn't actually be doing that, because what we defined as high risk is different when you look at any of the studies themselves. Now, there is a consensus coming that basically Stampede seems to be, Chartered seems to be achieving some consensus that most of the studies that have been done since Chartered have tended to follow what they determined was high risk versus low risk disease. What do you guys think?
I mean, by definition, this guy is low risk.
Yes.
By the Chartered criteria.
Low volume.
Low volume metastatic disease by Chartered criteria.
Yeah.
Well, again, it depends on the nodal disease. I mean, it's pretty bulky.
It depends on the bony.
Yeah,
it depends on.
Yeah, that's
the
true.
nodal disease doesn't really bump you.
And his
into
performance
high volume.
status is good. That's so. I mean, but what I'm saying is, it won't happen today. But at some stage, there needs to be some definition of what is low risk, high risk, and intermediate risk.
I think some of these newer trials that got some of these approvals now for, the androgen receptor antagonists, they're using the Charted definition.
Yeah.
So yeah, I mean, the high risk versus low volume, high volume, Charted, the Stampede, Titan, Arches, Enzymes, all used high volume, low volume, pretty much based on, it was the Latitude that had the high risk
Right.
3 or more lesions and also Gleason 8 and
Correct.
higher. So that's
it's a
kind of
risk
just threw a
definition,
little bit
right.
of a confounder into
Yeah.
it.
So what I'm saying is, though, we should insist that this gets sorted out so that there is a definition that everybody agrees to. Okay, so having established that he does have a bony met, he does have the disease that we have mentioned, what are his initial options when you look at ADT? Number one would be agonist or antagonist. Would you give it alone? Not sure that's such a good idea. Agonist plus a first generation anti-androgen, long term or short term, monthly versus 3 or 4 monthly. A or B plus a second generation anti-androgen. A or B plus chemo. Or maybe C plus chemo. Or a trial. Which would you go over?
But have we written off that we're not going to do anything with this primary?
Well, that's most people would take a look at it and say, yeah, we're not going to do anything with that primary.
Well, if it's low
volume,
volume-
hands up in the audience. Who would take out this man's prostate
Well,
or radiate?
So yeah,
Radiate.
there's good data. It was post hoc analysis. It wasn't part of the primary intent in the Stampede arm. They published that, Parker, I think, is lead author, that for low volume metastatic disease, primary radiation was a benefit.
and
So
the hazard ratio is 0.68.
So
on
there
that
is
one.
data
Yeah.
to support that. So this is a guy who's got, technically, I guess we're saying low volume metastatic disease. So you don't have all, so yes, you've got so you could have ADT plus APA, ADT plus ENZA, ADT plus ABI. And in ESMO this past year, Nick James presented some data to suggest that a contrarian opinion that ADT dosi was a benefit despite what we saw in chart.
Yeah, because that really they hadn't followed it out long enough. When
Tom,
they-
I think with this guy, he's got a big gland. He's already symptomatic. He's got Gleason Group 4 disease, and we know he probably has more. I think we regret the day which we've all been through, where we don't take out his primary, because he
take
will,
out.
or treat his primary in whatever modality, because this guy will fail locally. He'll fail locally first.
He will, but he will do that. He may fail distally as well. But does radiation, it did produce a survival benefit, I agree with that, but it also causes some significant symptoms, especially in a prostate that you know is not a normal prostate. It's going to grow aggressively. And I don't know, I mean, your data is, what data do you have on that? I mean, it's
Stampede.
one.
So, I mean, it's well
Well, you're the radiation oncologist.
Yeah, so I mean, but really well summarized here. So it's on the table. We go to tumor board. We're going to start systemic therapy. And in my practice now, we come around after 4 or 6 months, and we re-image, we see where the patient is at. And if you have nodes, so technically it's feasible to treat this low-volume disease with ablative radiotherapy. And, in your ECOG 0 guy that you're looking at longevity and you want to, say give your systemic agents the best shot at, working for as long as possible, we're treating these patients. So what I would do with this gentleman would be SBRT to the spine, and then I would do pelvic radiotherapy as a simultaneous impulse boost to the prostate, and I would do it hypofractionated, just over, using a European style of radiotherapy to really, minimize the toxicity, the time consumption that radiotherapy is for guys, but hope to give durability, hope to add to the bottom line.
So
and
would anybody take this out?
So to me, I mean, you've put the sort of the clinical history, which scares most people off, which is the bilateral hernia repair.
Yeah.
Right? I mean, what you've presented, though, Tom, is probably once next generation imaging gets approved for staging, this is what we're going to see more and more often with these high-risk tumors, and what to do with these positive findings.
I mean, Memorial has a large group who they've been running that trial.
Yeah. So, but I think it's important that for the community, that there's really not any great evidence to support a prostatectomy here, whether it's peritoneal or retropubic, if he didn't have the mesh. We have some data now for primary interventional treatment of radiation. There are trials that are ongoing, so I think to do this in the community is fraught with some peril. For
All right, that's why I put trial at the bottom.
Tom, can I
So
just
I
ask-
would also, I would do an antagonist, and I would add one of these next generation anti-androgens from the Titan or the Arches trial.
Yeah.
So it's either going to be enzalutamide or apalutamide.
Or APA.
And you can consider chemo because those were given in those trials as well.
Laurie?
Just to make it explicit, his nodal disease was iliac and obturator, so it was not outside of the pelvis. So he fulfills the criteria for oligomets, and that is a domain that is the subject of huge attention. No one's used that term yet, but he is an oligomets patient, and there's multiple trials, some of which have now reported, as you mentioned, of SBRT radiation to the few metastatic sites with radiation plus ADT for the primary. And to me, that is the closest thing to a standard of care that there is right now for this patient.
Right. Good comment. So, let's ask then, Neal, when you're starting ADT, what's your drug of choice?
So I think for this guy, my drug of choice would be degarelix, because of his metastatic disease. That would be my ADT drug of choice.
And how often would you check a PSA?
So I check a testosterone at baseline. I check a PSA after the first month. I check a testosterone level at the end of the first month as well. I want to know, based upon the data that you were reciting earlier, a lot of the work that Lori's done, that I believe that a lower T is beneficial. So I would check it within a month, both T, at the end of a month, a T and a PSA.
Okay. And then, well, I've already told you what we consider adequate castration, so I'll leave that alone. So do you use first or second generation anti-androgens, and if so, for how long? And by second, I'm calling bicalutamide second and the other one's third generation. It depends on who you read or what you read as to whether they're calling them second or third generation. But I'm saying, would you use ADT plus flutamide or plus bicalutamide?
Well, there's no data to show that there's going to be a survival or radiographic progression-free survival advantage if you use those anti-androgens.
Okay. And then would you refer this patient, he's obese, he's cardiovascular disease, who would you refer him to before you start him on ADT, or would you do your own assessment?
I think you do your own assessment. You be a physician, you do your own assessment, identify the risk, have a discussion with him on the risk of androgen deprivation therapy, and I think you keep his primary care physician informed that this is what we're doing.
Okay.
But I would agree with Neal. You check his testosterone before you start, and you give him an antagonist based upon his personal history.
So he saw a cardiologist, he had significant coronary artery disease, mildly elevated liver enzymes. Would this affect your choice of therapy?
Yeah, with his elevated LFTs and his significant, his heart disease, right? There's clearly some of these, whether they be androgen receptor inhibitors or synthesis inhibitors, there are some side effects that could exacerbate both.
And then the last question, if the patient had large volume disease, would chemotherapy be a better option?
So there's no data to suggest that with a high volume patient that an ADT couplet therapy with one of the new advanced generation orals is inferior to docetaxel, even with visceral metastases. It really does come down to a discussion about the duration of therapy, cost, accessibility. I just want to make one comment because I've been hearing this a lot. This whole notion around what should a urologist be doing, checking a hemoglobin A1C, getting an EKG, getting a cardiologist involved. And I think the answer to all of this is, how much of your internal medicine chops do you want to do when you take care of patients with advanced GU-oncologic issues? The multidisciplinary approach is obviously ideal in the academic setting. The question is what is your accessibility in the community, and what is your commitment to treating these patients? And I think the answer is it really just depends upon how aggressive you want to be. The fact if you're going to take care of these patients and you're going to do it on your own, you need to be prepared and really sort of channel your internal medicine bona fides. And that's really true, I think, of all of GU-oncology. That's probably not what most urologists want to do, but not all can get the cardio-oncologist that they want. or the neuro-oncologist that they want. And that's where everything's changing.